Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Today, we'd like to discuss an important topic regarding hysteroscopic incision of uterine septum, which is commonly called as hysteroscopic metroplasty. And we have to outline the clinical and practical tricks important to achieve appropriate treatment of the uterine septum by hysteroscopy. And this lecture comes because I noticed that many doctors nowadays are performing hysteroscopic incision of uterine septum based on some classifications that put the uterine septum incision as an intermediate hysteroscopic surgery level 2A just after diagnostic or office hysteroscopy. And this encouraged many gynecologists to practice the incision of uterine septum in a heroic manner to be a good hysteroscopic surgeon with time and to gain experience. And actually, uterine septum is not uncommon, and it is the commonest Mullerian duct anomaly or even uterine anomaly seen in our practice, and it has clinical impact on pregnancy rate and abortion rate. So it is a common topic. We have to identify the technique, tricks, and to avoid the complications of hysteroscopic incision of uterine septum. The appropriate treatment is to do an operation by incision or division of this uterine septum without causing perforation of the uterus, without causing thinning of the myometrium, without causing residual septum, which means incomplete incision of the septum. This is the definition of appropriate treatment. And in this figure, you can see on the right side that the septum, you have to imagine that the uterine septum is like a conical structure, has a base, body, and apex. And the base may be broad or narrow, the body may be thick or thin, and the apex may reach internal also. It is complete septum or not reaching. It is subseptate or partial septum. And the appropriate treatment means that you excise the apex and the body and the base, but not to go inside the myometrium. And if you don't treat, you will leave the septum like this figure on the left side. And under treatment is leaving some part of the septum, which is the body. And over treatment, if you go inside the myometrium. So the critical and important point of hysteroscopic incision is to be appropriate to avoid undertreatment and also avoid overtreatment. Undertreatment means that you leave a part of the septum, and this can be seen after your operation by HSG or ultrasound, even 2D or 3D ultrasound, and actually it is not uncommon, and in some studies it has been reported to be up to 38% of cases after incision of septum you will find a residual septum. And importantly, to define the residual septum, if it is less than 1 centimeter as measured by ultrasound or 3D, particularly 3D, so it is called suboptimal resection, which means the section is good, but if it would be more optimal if you excise this part or incise this part, which is less than 1 centimeter. But if the resection is incomplete, means it is more than 1 centimeter. So the critical level is 1 centimeter. If it is less than 1 centimeter, it is suboptimal. If it is more than 1 centimeter, it is optimal. What's the value of this classification? The value has been studied in previous studies that found that suboptimal residual, suboptimal residual septum, which means suboptimal resection or incision, does not affect the reproductive outcome of the patient. And if it is more than 1 centimeter, it affects the reproductive outcome. What are the causes of undertreatment or leaving the part of the septum? The causes may be preoperative, intraoperative, or postoperative. Preoperative, I think importantly to put in your mind these clinical simple steps to avoid leaving a part of septum. You have to start preoperative thinking, which means that you have to select the timing of the operation. And timing is crucial because after menses, of course, the endometrium is thin, so the visualization is better, bleeding is less. So timing is essentially post-menstrual. Some studies use hormonal preparation like progesterone, gene-rich agonists, COCs, and others without sufficient evidence. If you find a patient with thick endometrium by transvaginal ultrasound, you can start some hormonal treatment preparation, 1 cycle or up to 3 cycles prior to hysteroscopic incision of the septum. And you have to review the ultrasound report of your patient, HSG or 3D, because if you find a big septum by these reports and you go through hysteroscope and find a small septum, you have to think, where is the septum? You may be in a false passage or in a wrong place. So you have to correlate between the ultrasound, HSG, and diagnostic hysteroscopy findings. Also importantly, preoperative, you have to make proper cervical sounding to see the cervix, is it stenotic or not, and you can do cervical priming. Priming means preparation of the cervix for dilatation to achieve the hysteroscopic access to the cavity. And you cannot, it is not essential in all cases. You can ignore priming if your patient has a cervix which allows introduction of the instruments like cystoscope or operative hysteroscope. But if your patient has cervix tight, she is nulli gravida, or primary infertility, so it's expected that her cervix is tight. So it's better to prepare her by giving her prostaglandins or laminaria. And we had a study, a randomized controlled trial published before, comparing laminaria versus misoprostol, and found that misoprostol is superior, being of similar efficacy like laminaria tints, but of cheap price and availability. So you can use prostaglandins if the cervix is tight. Also, you have to assess the patient under anesthesia. Firstly, you have to advise your patient to empty bladder before going into the operative room, and you have to check the bladder by simple catheterization using Nelaton or plastic catheter, because full bladder can change the direction of the uterus and is liable to injury. What about cervix? You have to grasp the anterior lobe of cervix by vulcellum or tenaculum, and it's better to use single-toothed tenaculum, which allows good grip on the cervix, which is practically superior to multi-toothed tenaculum. Importantly, if the uterus is AVF, you have to grasp the anterior lip and ask your assistant or nurse to push the tenaculum towards the patient's head, kifalid, and if it is RVF, you can push on the cervix in a straight manner. So direction of grasping cervix is important. After that, you have to do sounding of the uterus. If it is possible to introduce sound, this means that the cervix is 4 millimeter or more. So if it passed, this is good. and this is considered normal. But if it passes easily, this is suspected to be a batulous cervix. And in such a case, leakage of fluid is expected, and you can make more grip or tightening of cervix using the tenaculum, or you can use a backup scissors technique as published by our team before in cases of excessive leakage in very batulous cervix. And if it is normal, you have to dilate the cervix until the diameter of the instrument you will use for incision septum. You can dilate up to 5 millimeter if you are using office hysteroscopic procedure or VersaPoint, or 5 millimeter continuous flow resectoscope. You can dilate up to 7 millimeter if the 7 millimeter resectoscope or operative sheath using rigid scissors, or up to 10 millimeter if you use the conventional resectoscope. But if the sound does not pass through the cervix, this means that it is less than 4 millimeter. In such a case, you have to start probing of cervix using less diameters, dilators, or using office hysteroscopy, which is 2.6 millimeter with outer sheath 3.2 millimeter, to negotiate the cervix and to overcome stenosis or kinking. And we have a publication showed that office hysteroscopic negotiation of the cervix is superior to probing. You have to avoid overdilatation because it leads to excessive leakage intraoperatively with poor visualization and soiling of the field, and also it has a remote complication of possibility of induction of cervical or isthmic insufficiency and incontinent os. Sometimes during dilatation of the cervix, you find yourself in a false passage, not into the endometrial cavity. In such a case, don't panic. You can withdraw your telescope out and start gently to find out the normal internal os and to go through it in a gentle way, which is called tilt technique, withdrawing the telescope and trying to find the internal os and go through it. And you can make dilatation if it is very stenotic. After you used the hysteroscope, diagnostic hysteroscope, to find its site and direction. Or sometimes you can cut the bridge between the false passage and the normal internal os to widen this area and to have access. And if not possible to do this and you cannot access the endometrial cavity properly, you have to stop your technique and you have to allocate another setting. And this is not shame. The shame is to make complications in such a case. Also, I told you, you have to use diagnostic hysteroscopy prior to any operative intervention. Diagnostic hysteroscopy pre-operative and post-operative is mandatory. And the diagnostic hysteroscopy is important to know the type of the septum, its base, broad or narrow, body thick or thin, apex complete or incomplete, also proximity to the ostium and Darwish triad, in addition to vascularity of the endometrium. All these findings are very helpful are so helpful during incision of this septum. One of the factors of undertreatment and leaving a residual septum is you as a surgeon. Why? Because you perform the operation while you are not seeing well the endometrial cavity, the septum, and the tubal ostia. So poor visualization is one of the causes of undertreatment. Lack of experience or rushing to this procedure without sufficient experience, sufficient studies is another factor. Also, if the surgeon is in a hurry to cut the septum and say that I can cut it in a few minutes, this is not good. You have to be very careful and you have to be honest if you are doing the procedure properly and you completed it in one session, this is good. If you failed, you have to be honest to tell the patient that you failed to excise the whole septum and you may need another session whenever indicated. Also, the intrauterine pressure setting is your responsibility. As I told you before in the lecture on the fluid balance during hysteroscopy, the intrauterine pressure is controllable by the surgeon. So you have to keep the intrauterine pressure at the least possible to avoid over-distension and over-stretching of the uterus and missing a part of the septum after deflation of the uterus. So the location of the surgeon on the learning curve is one of the important causes of failure of complete incision of the septum. As I told you, keep the pressure as low as possible to avoid overstretching and missing a part of the septum. What about your instruments? The instruments, if you use wrong instrument, poor connections, blunt scissors, these are contributing factors of leaving a part of the septum. And defective instrumentation is one of the causes. Here is a loop trying to cut septum and it has been broken. And this is the loop away from the arms of the electrode. So cutting or defective instruments, poor connections, poor instrumentation, these are contributing factors for poor incision of the septum. I have in the operating room scissors, I have energy modalities like monopolar diathermy, bipolar diathermy, laser. What to choose? Actually, studies found that none of these tools is superior to the other. But here in this figure, to be practical, not to follow studies in a strict way, I need you to be practical and to put in mind the advantages and disadvantages of each tool. Don't forget that we have a base, body, and apex, base, broad or narrow, body, thick or thin, apex, complete or incomplete. So we have mechanical tools, we have mechanical and energy, and we have energy. Mechanical means no use of energy, like scissors, okay? We have flexible scissors and rigid scissors. Flexible is used if it is thin body, narrow base, short septum. So the base, body, apex are here thin, narrow, short. But if it is thick body, broad base, long, you have to use rigid scissors. And rigid scissors is supplied by some companies, and you introduce the telescope inside the rigid scissors, and actually it is strong to cut thick and broad base septum. You can use mechanical and energy, putting in mind that this tool is having the disadvantages of energy and mechanical trauma or cutting of the septum. And here comes the resectoscope or the bipolar probe used in office setting, 5 French bipolar probe for thin septum and short septum, but resectoscope for thick and septum, long septum, and for broad base or narrow base. Broad base, if it is broad near the Darwin triad and tubal ostia, so it's better to use bipolar because of monopolar can disseminate to occlude this Darwin triad, the intramural part of the fallopian tube, and the narrowest part, which is the beginning of the isthmic part of the fallopian tube, can be blocked by using monopolar due to secondary coagulation. So if it has a narrow base, you can use monopolar. If it is broad base, use bipolar resectoscopy. This is an important discriminative point. And you can use energy only laser, CO2 laser, with a lot of smoke and less hemostasis if compared to diode laser as proved in some studies. So putting in mind the shape of the septum, the site, the body, the base, and apex, you can select the tool of cutting the septum. But importantly, you should have more than one set to cut the septum, simply because if you are using the scope, for example, and the patient under anesthesia and the equipment has been broken, the loop is cut, the knife is not working, the connections are not good. So you should have double setup, and this is not luxury. Moreover, you should have more than one tool. You should have scissors and monopolar or bipolar, or scissors and other energy or electrodes and so on. So have two different tools and double setup. These are essential requirements or prerequisites to achieve proper incision of the septum. And you have to check your equipment before the operation for connections and the blades of the scissors. Technique of incision is of utmost importance to avoid under or over treatment. You have to keep the word centralization in your mind. Centralize the electrode or the scissors between the anterior and posterior wall all the time. Centralize it, not to be on the anterior or posterior more, because you, by this way, you will perforate the uterus. Anterior and posterior, centralize. Right and left, centralize. Right and left, Darwish triad, anterior and posterior walls. This is the key of success of proper site for incision. Always start from lateral to medial, not to push. Sometimes you can use the loop electrode and you transfer it into a knife, and this is not good actually, because this pushing technique, and this can lead to unintentional incision of the fundus itself. So don't use pushing technique. You have to start from lateral to medial and keep centralization in your mind. This is regarding the tip of your instrument. What about the whole instrument? This whole instrument should always withdrawn back and forward in a gentle way to have good orientation, continuous orientation, and real-time visualization of the cavity. Always go forward and backward. Always keep an eye on the landmark, which is the tubal ostia, start of Darwish triad. Always move the telescope from side to side to have orientation about the lateral walls and avoid getting straight fundus. These are important. So the keys of the tool are the centralization of the tip of your instrument. Start from lateral to medial. Don't use pushing technique. And the whole instrument should be moved from side to side, backward and forward, to have orientation of the lateral walls of the tubal ostia and the rest of the septum left inside the uterus. And the next step intraoperatively is to use monitoring of your technique. And this monitoring is essential. Why it is essential? Because it carries more safety for you to avoid over or under treatment of septum. So it's the indication of monitoring is safety. This is important. Also, it gives you real-time view of the extent of incision. You are inside the uterus. You are not seeing what's the myometrium, what's outside the myometrium. This can be achieved by the monitoring tool. And also it can predict complete incision. If you are reaching the fundus, you can see it easily by the monitoring tool. And lastly, it excludes other dysmorphologic anomalies like hybrid anomalies of bicornate and septum at the same time, and sometimes submucous myoma or so. The methods of monitoring are variable. We can use transabdominal ultrasound, transvaginal 3D, transrectal, graduate intrauterine palpator, or diagnostic laparoscopy. The simplest and easiest is to use transabdominal ultrasound, and the assistant puts the transducer over the abdomen, but it requires full bladder, and you can put it on the longitudinal, transverse, and coronal scans to have good orientation of the instrument inside the uterus. And this is easy and simple approach. Does not interfere with your field. But if you use transvaginal sonography, the accuracy, of course, is good and better than transabdominal, but the field will be narrow. The visualization is good, but you cannot move your instrument properly because of two instruments inside the vagina. So the narrow field and interruption of the field is a drawback of this tool. Sometimes you can use three-dimensional, which is more accurate and more precise, but also the narrow field. And some studies use graduate intrauterine palpator with ultrasound or versus 3D, and found it is a simple approach, and actually can use uterine sound to check the length of the cavity and the remaining part of septum, or disposable hysterometer. Away from the vagina, you can use transrectal ultrasound, and some studies found that the incidence of suboptimal or incomplete incision are less if you use transrectal. Also, it is a little bit difficult technical in some cases. And lastly, you can use diagnostic laparoscopy whenever indicated for infertility assessment or suspected endometriosis or pelvic adhesions. You can do diagnostic laparoscopy concomitantly with hysteroscopy, and it's better to do laparoscopy prior to hysteroscopy to monitor the fundus and to check other anomalies of the uterus prior to incision, and to keep the telescope to monitor the procedure. And in such a case, you should have two cameras to have, and two monitors to have visualization of the fundus from outside and the uterus from inside on either screen. And actually, diagnostic laparoscopy is superior to other tools in predicting the perforation, or predicting that you are completing the incision or not, by trans-illumination testing, where the hysteroscopist approximate the tip of the instrument telescope to the uterine wall, and if the assistant sees trans-illumination light into the uterus, this means that he is approaching the myometrium, and he has to inform the surgeon to stop at this point. And also, this is important in detection of some rare anomalies, or some rare subtypes of septum, like Robarts syndrome or Robarts uterus, where a part of the uterus is containing where a septum dividing the uterus into two asymmetrical parts, and one of these parts is non-communicating with the other part, and you can cut the communicating and other part is non-communicating. How to know? By this trans-illumination test, your telescope in one of these horns can be seen like this picture, while the other horn is not illuminated. This means that there is non-communication between both parts, and this is a rare type of septate uterus. As I told you, after your procedure, you should do hysteroscopy to check completion of the incision. And one of the important intraoperative causes of undertreatment is the anesthesia, because sometimes the patient has some fluid imbalance or cardiopulmonary problems, so the anesthesia doctor asks you to stop your technique and to be hurry because the patient is not good. So this is another factor, and actually this can be caused by you as a surgeon if you are using a lot of fluid, or there is fluid imbalance in your technique. Post-operative hysteroscopy is important to check the fundus integrity exclude perforation, proper visualization of post-Darwish triad on panoramic view. Lastly, if you see a lot of bleeding after your procedure or you used aseptic condition, you have to expect that your patient may have post-operative adhesions. In such a case, you have to control bleeding and careful hemostasis by rinsing the uterus with Ringer's lactate, with heparin. Sometimes you put Foley's castor if it is excessive bleeding, balloon compression of the endometrial cavity for a while, and then remove it. And you have to give sometimes antibiotics if you suspected incomplete asepsis. And this is a controversial point, but practically you can give it if you suspect or afraid of infection, particularly in cases of recurrent abortions. And these are the causes of residual septum after your procedure, and how to treat. If it is suboptimal, less than 1 centimeter, you have to assure your patient that this is not important and cannot affect her reproductive outcome. And we don't rely on the film of 3D or HSG. We rely on clinical presentation if you are still complaining or not of abortions or recurrent pregnancy loss. And don't accuse your colleague who performed the previous operation if it is suboptimal resection, because this is better than over-treatment with its sequelae, as you will see now. But if it is complete resection, more than 1 centimeter, and the patient still has a problem with reproductive outcome or still has problem with infertility, in such a case, you can subject her to repeat attempts. So don't rush to repeat attempt of incision unless it is incomplete resection more than 1 centimeter. If it is less than 1 centimeter, don't care about it. Some doctors do diagnostic hysteroscopy and decide not to treat septum. Why? Because I'm not convinced that septum may affect her fertility or affect her reproductive outcome, as based on some studies, particularly in fertile women, or he cannot treat the case due to deficiency in experience, visualization, or so. But if he stops to cut the septum due to insufficient evidence, I give him this meta-analysis and systematic review that shows that if a patient with a septum has a lower pregnancy rate, lower live birth rate, if compared to patients without septum. This is first result of the systematic review assessment of the previous studies. And if a patient with septum treated versus untreated, the pregnancy rate and preterm rate were not different, but the spontaneous abortion rate was lower if she is treated. So treatment is good for her. And before after septum removal, the proportion of live birth rate is higher after removal, and proportion of spontaneous abortion and preterm labor was lower after removal. So cutting septum may help reproductive outcome of your patient. So don't ignore hysteroscopic incision of septum in all cases. But if you are not treating septum due to deficient experience, you can go to these causes of undertreatment, preoperative, intraoperative, and postoperative, and try to improve the skill and visualization and technique so you can achieve cutting. Some doctors start to cut the septum and continue cutting the septum until they reach the myometrium and they make myometrial damage, and this is called over-treatment. And over-treatment can lead to perforation of the uterus, can lead to myometrial thinning, which leads to rupture uterus in the subsequent pregnancy, and can lead to false passage. And here is fundal perforation of a patient after hysteroscopic surgery in one of publications, as she is opened by laparotomy for internal hemorrhage. And in this video, you can see cutting septum And when you are cutting, bleeding starts, collapse of the field, poor visualization due to perforation, and this perforation is seen by concomitant laparoscopy, and this is a common complication of over-treatment. How to treat perforation? You have to stop your technique immediately. Don't complete, don't proceed because of the collapse of the field, because you don't see what's after this perforation and what organ has been injured by this perforation. And you have to know that if you are using just mechanical instruments, scissors, if it is small perforation, you can observe her without indication for laparoscopy. And if it is large perforation, actually laparoscopy is indicated to control bleeding and to check the organs. If you are using combined mechanical and energy or energy alone, this is called complex perforation, which is mechanical and energy. And this is an indication for laparoscopy because the energy can cause damage of one of the vital organs or the bowel, and this injury can be early or remote, leading to problems. So you have to check the integrity of the vital organs and bowel. And in all cases, you have to document perforation. You have to write that you made perforation, which is not a shame. And the problem that if you don't write, this may lead to serious sequelae in the subsequent pregnancy. So perforation is a complication of any surgery of the uterus, and it is done by doctors who do work. But if you don't work, you will not have complications. So perforation is unintentional complication, and it is not blamable problem. So you have to document, you have to write in the report that a small perforation or a big perforation has been done, and you checked or put the patient under observation. And in subsequent pregnancy, doctors should take care of this perforation, as this patient is more prone to have some problems of integrity of the uterus during pregnancy. Some doctors do over incision without perforation, but the incision of the fundus reaching the myometrium, and the myometrium became thin, less than 1 centimeter, and this thinning is a starting point of rupture uterus in the subsequent pregnancy, like this case. And actually, rupture uterus is rare, but can occur in up to 2.7% of cases after hysteroscopic metroplasty or incision of the septum. And of course, the main cause is perforation or deep incision using energy modalities because of secondary coagulation and deep tissue necrosis. And lastly, due to contractions of the pregnant uterus. These are contributing factors for rupture uterus. And by this way, we covered the topic of undertreatment, overtreatment, and no treatment versus appropriate treatment, which is to avoid over or under treatment. And in conclusion, I would say that hysteroscopic metroplasty is not so simple procedure as thought by many doctors. And actually, I appreciate the recommendation or the classification of the Royal College that puts the incision or division of septum as level 3 hysteroscopic surgery, like myomectomy, like Asherman syndrome, like TCRE, and so on. It's not a simple procedure to be done by a beginner, because it is very crucial to cut a septum and to go inside the uterus, which is the site of implantation and site of pregnancy. Following pre-operative, intraoperative, and post-operative precautions would help achieve appropriate metroplasty, and you have to individualize tool selection. This is important. Don't use a cystoscope in all cases. Don't use scissors in all cases. No, you have to individualize. This patient, I'll use scissors. Why? Because I'll use flexible scissors because it's thin septum and incomplete septum, for example. And this patient, I'll use rigid scissors because it is thick septum, complete septum. This patient, I'll use bipolar because of proximity to the tubal ostia and Darwin striate. By this way, individualization of tool, not to be stick to one instrument. All cases by scissors, all cases by stethoscope, this is not good. You should change the instrument according to the situation of the patient. And nowadays, you don't have excuse because of the availability of 2D and 3D ultrasound detection of the size and characters of the septum, and avoid improper knowledge, improper visualization, incomplete septal incision, perforation, excessive incision can lead to thinning. All these are due to poor visualization, poor knowledge, poor learning curve of your of the surgeon, and consider associated pathologies and anomalies by proper preoperative assessment of the uterus, and sometimes intraoperative monitoring by diagnostic laparoscopy. Lastly, my advice, you have to know that a hysteroscopic incision of a septum is considered as a reconstructive plastic surgery, and please don't turn it into a tragedy by doing over incision with its sequelae up to rupture uterus or under incision that may need a repeat attempt. Thank you very much.